Thank you, Dr. Ahmed. Thank you, Dr. Basim. Welcome our guest speaker. I will talk today on history and development of rotator cuff repair. Next. First description of rotator cuff tear is credit for first description rupture of this structure is often by Smith, published in Medical Gazette in 1834. Next. First description of subacromial bursitis is the first to observe this is Gerjavi in 1867. Next. Periarthritis humeroscapularis is introduced this term by Duplay in 1872. Is describes stiffness and pain in shoulder. Next. Goodman contribution. First cuff repair is done by Goodman in 1909. First recommended early operative repair of cuff was Goodman in 1934. First proposed intrinsic theory is Goodman in 1934. And Goodman is the first describes the lesion partial articular surface tear. Next. First to describe subacromial pathology is Peterson in 1942, published a valuable observation on subacromial pathology. Next. First open suture technique was done by Goodman in 1911. First to report successful simple transosseous suture rotator cuff repair. And McLaughlin, who is the first to use matrix transosseous suture in 1944. Next. Different types for repair are done by Goodman, by McLaughlin, by Neer, by Hawken. Next. Factor causing rotator cuff tear, either extrinsic theory or intrinsic theory. Extrinsic theory is down-sloping acromial spare, os acromial, acromioclavicular osteoarthritis, or intrinsic theory with suboptimal cuff vascularity, or oxidative stresses, or degenerative microtrauma, both lead to degenerative tear. Next. Extrinsic factor causing rotator cuff tear. Next. Next. History of open treatment of extrinsic factor subacromial space was the first advice Watson Jones in 1939, complete acromiectomy. Then Smith Peterson in 1943, hemiacromiectomy. McLaughlin advice lateral acromiectomy in 1944. Stam advice glenoid neck inferior osteotomy, and Neer in 1972 advice decompression and removal of the anterior spare. Next. Impingement syndrome. In 1972, Neer described the impingement syndrome, and Neer classic work advocated extrinsic factors. Next. Impingement syndrome described by Neer in 1972, divided into 3 stages. The first stage, edema and hemorrhage. The second stage, fibrosis and tendinitis. Third stage, bone spare and the tendon rupture. Next. Bigliani in 1984 reported a relation between the shape of the acromion and subacromial narrowing, and divided 3 shapes of acromion: flat, curved, and hooked acromion. Next. Treatment of extrinsic factor causing rotator cuff tear. Next. Neer in 1983, anterior acromioplasty, wedge resection of the anterior acromion. Next. Mostly done open rotator cuff repair, tendon as about 10 cm incision, transosseous suture repair as performed by McLaughlin in 1944 and Neer in 1972. Next. Evolution of arthroscopic treatment of impingement syndrome and rotator cuff tear. Next. Evolution of shoulder arthroscopy position. Next. In 1984, lateral decubitus position are described by Ullman. Next. Warren and Beach's chair are described by Warren in 1988. Next. Sitting position are described by Dr. Flega in 1991. And the advantage of this position is acromion parallel to the floor, match the X-ray, and the arm and hanged and free manipulation. Next. arthroscopic subacromial decompression. Next. In 1985, first arthroscopic subacromial decompression by Ullman. Next. In 1995, arthroscopic classification of the space between the anterior acromion and the supraspinatus by Dr. Flega. No impingement pathology when the space is more than 1 centimeter and 2 millimeter. Next. Dr. Bassem Flega in 1995 gave the standard arthroscopic subacromial decompression by using the measuring needle. Put the anterior measuring needle anterior to the acromion and decompress until the space become 1 centimeter and 2 millimeter. Next. The mini open arthroscopic repair is described by Levy in 1990. Gave 80 and 100% good excellent results. Patient under many open rotator cuff repair, and but its disadvantage was scarring and stiffness, and can't address massive tears. Next. Arthroscopic rotator cuff repair using staple and anchors. Next. In 1988, the first arthroscopic cuff repair was done by Johnson by using staples, and the problem with this is the impingement and loosening of these staples. Next. In 1990, the first arthroscopic anchor fixation was done by Wolf by using the Mytech suture anchor, and done in 1990. Next. Arthroscopic anchor fixation improved and propagated by Wolf, by Snyder, by Bochert, by S. Next. Anchor suture technique either single row or double row. Next. The first transosseous arthroscopic rotator cuff repair described in 1990 by Dr. Flega allows the same type of footprint cuff repair as open procedure. Next. Keepon in 2006 describes the transosseous equivalent, the suture bridge using the 2 medial anchor and 2 lateral push lock. The bridge configuration provides compression of the rotator cuff to the footprint. Next. After that, many methods are described to transosseous repair as Taylor stitch by Pellegrini in 2012. Next. Using of ACL guide also as a method for transosseous repair. Next. Curved Basser by Beauchamp in 2007. Next. Alessandro in 2018 makes this study in the history and development of transosseous repair. The transosseous repair, arthroscopic transosseous repair started by 2002 by Dr. Flega by using of giant needle, and end at 2017 by using of Combasso. Next. Recent shift to arthroscopic transosseous repair. Causes. Next. Double row versus single row. Kim et al. Compared single row and double row repairs with respect to cyclic loading, gap formation, failure loads, stress at anchor site. Compared with single row repair, double row repair had 4,200% less gap formation, 4,600% more stiffness, and 4,800% more ultimate load to failure. Next. Arthroscopic transosseous repair. More recently back to the past with transosseous footprint reconstruction. Current biomechanical studies found improved ultimate load to failure, reduced gap formation during cyclic loading. Next. Arthroscopic transosseous repair. Banker et al. In 2011 fact in that transosseous repair technique fuses the advantage of arthroscopic surgery, minimal collateral damage, to the strength of open repair. Next. This study done by Gerber in 1994 measured the repair strength of transosseous arthroscopic technique is superior to anchor technique. Single row tensile strength of 208 Newton. Double row repair strength at time 0 was reported to be 336 Newton. Transosseous equivalent repair was as open 443 Newton. Intact supraspinatus tendon 800 Newton. Next. Transoceans versus double row versus single row. Sanot al compared the stress distribution by using single row, double row, and transoceans. In transoceans repair, the stress was concentrated at the attachment site to the bone, and no stress was seen on the dorsal side. On the other hand, single row repair had a highest stress concentration on the dorsal side in the anchor area. A similar pattern was seen in double row repairs with the stress more concentrated in the medial anchor. They hypothesized that the high stress concentration seen in single and double row technique at the anchor site may explain the high rate of recurrence seen in anchor repair. Next. Summary, anchor versus transocean repair. The advantage of transocean repair improved the ultimate load to failure, restoring the footprint, achieving the best pressure on the repair. This advantage of anchors, less load to cause failure, gap formation, stress at anchor site. Next. New challenge removing the anchor, loosening, infection, tear recurrence. Next. Thank you.